Afternoon, and thank you for joining us for today's webinar, Cone Beam CT in Dental Offices, Tracking Radiation and Optimizing Dose. Before we begin, I would like to go over a few housekeeping items. Today's webinar will be recorded and available through our website and the RadSite YouTube channel. To minimize noise and distraction, all attendees' microphones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using your Q&A box. We will do our best to address all questions and comments at the end. I will now turn the presentation over to our moderator, Dr. Mark Hiatt, Chief Medical Officer, RadSite. Thank you.
Thank you, Andy. I'm so pleased today that we get to speak today on cone beam CT or CBCT in dental offices. And here we're really going to focus on tracking radiation exposure and optimizing dose. Now, I'm joined with two experts in the field. First, by way of introduction, my name is Mark Hiatt. I'm a radiologist as well as Chief Medical Officer for RadSite, which is an accreditation body in radiology. But we have two experts, luminaries in the field of radiation safety. First, we have Vino, who is serving as Regional VP, as well as a Senior Medical Physicist for West Physics. And he's expert in all things pertaining to radiation, exposure, monitoring, the whole bit. Vino, why don't you just give us a little bit of your background and a little bit about your experience?
Thanks, Dr. Hiatt. Yes, I'm Vino Duraraj. My background is in medical physics, obviously. I'm a senior medical physicist by training, and I do help customer sites with, getting accredited for different modalities, ranging from MRI to CT to nuclear medicine and, more of, cone beam CTs as well. And I do act as radiation safety officer at a community hospital. And of course, I do a lot of, CT dose management, not just these cone beam CT, also the conventional, whole body imaging as well. So that's pretty much my background. And I have been doing this for the last 18 years.
Wonderful. Also with us, we have Chris. He serves as president of the Radiation Detection Company, also expert in all things pertaining to radiation, including exposure to staff and to patients. Chris, tell us about your background.
Yeah, thank you. My name is Chris Passmore. I have 36 years in dosimetry, 10 years in the Department of Energy and Nuclear Weapons business. I have 26 years total in commercial dosimetry service, a certified health physicist, have a master's in health physics, 3 bachelors, nuclear engineering, physics, and also engineering. I serve on many international and domestic standards committees for dosimetry. I sit on ISO, IEC, and ANSI standards committees. Former NCRP member and currently a NAVLAP assessor for other dosimetry programs.
Wonderful. So it seems that between the three of us, we may have about a half a century of experience, multiple graduate degrees, and committee memberships on many different prestigious committees. So with that foundation, we're going to be talking a lot over the next hour. And here are some of the objectives. So we'll talk about why this matters, about the clinical value of this new technology, particularly over the past decade, and just about various means that practices can really optimize dose and limit exposure. So in terms of these objectives, we hope that those listening, and by the way, the audience will have time at the end to ask questions, so be thinking. We hope to compare cone beam CT to other types of exposure to identify drivers of variability within this field, and then talk about strategies in which we can really optimize that dose. And we'll be talking about monitoring procedures both for patients and for staff, and really ways that practices can strengthen compliance, documentation, and quality oversight. Now, I'd like to know from our panelists, why do you think this matters now? Why is it so important that we turn our direction to cone beam CT? What has happened in the past decade in terms of the expansion of this new modality?
So obviously, more clinical practices, started using cone beam CT for dental. If I recall, like 15, 20 years ago, I don't think it was that established, modality for dentals, like the cone beam CTs. Pretty much everybody was using cone beams for, sinuses, temporal bone scans, and stuff like that. So now I think, we see a rapid expansion of cone beam CT in dental practices. And from a physicist standpoint, I can vouch to the fact that different states and different regulating bodies, they started putting up their standards, and there has been a lot of update to those standards lately. Depending on which state you are from, some states will act a little slowly to the requirements, and of course a lot of accrediting bodies like RadSite, ACR, and everybody else, they are just kind of catching up on that too. In getting the regulatory requirements set forth for dental practices. And I do not know whether it is only for dental practices, but I have been seeing a lot of literature lately talking about how radiation is going to affect people in the ways of increased cancer induction. Like they even quantify it. I do not know how they come up with that, but they would just say like one repeat of a CT scan is going to increase 10% of cancer induction on that patient. How much ever we question the credibility of that evidences or any documentation on that one, people are reading all of those information in the media, and that is going to show up when the patient comes into the department, and they will be asking a lot of questions. So now it's a good time for us to kind of start thinking about radiation safety as its prime. And of course, Dr. Hiatt, you can kind of highlight all the things, that is happening in the accrediting side of the things. So yeah, I mean, everything points to the fact that, it's now is a good time for us to kind of start addressing this issue of radiation safety in dental practices.
That's great. Vino, you alluded to the fact that as part of this evolution and expansion of cone beam CT in dental practices, that really a driver of it are these increasing clinical applications. And I wonder, Chris, if we can kind of begin with kind of understanding the clinical value of cone beam CT and why increasingly the general practice, in addition to the specialty practice, is really incorporating this modality into their clinical workflow.
Yeah, by looking at dosimetry results, we can tell which organizations, which dental offices are using cone beam CT, or traditional X-rays. We see a surge in, say, the dental implant arena. Also, we're seeing some uptake, I would say, of implementation in special needs dentistry or even in pediatric dentistry.
And just, from my background as a radiologist, the 3D anatomic precision rendered by CT vis-a-vis, 2D radiographic modalities is truly offers a superior rendering and helps the dentist or the oral surgeon in planning, knowing where the nerve is and being able to avoid complications. This is particularly good for surgical navigation, for localization, as I said, of nerves, of sinuses. You just have increased confidence, you reduce complications. And so there's a real clinical value. It seems, though, that clinical value needs to be balanced by the very real concern of the possibility of damage to radiation exposure. And I think, Vino, you had mentioned previously that this may be a concern. But for our audience, can you kind of put it into context? How much radiation are we talking about? We know about medical CT. How does cone beam CT as used in dental practices differ? And also within the dental practice with respect to other modalities like the panoramic view or Panorex or intraoral radiographs. Which should we fear most when we speak about radiation?
Yeah, it's a good question. I mean, I get this question all the time from technologists or sometimes, from the patients also saying like, what is the dose I'm getting out of this, procedure, right? Yeah, I mean, to kind of answer your last question, any small amount of radiation, it's harmful anyways, so that much we know. Anyways, to talk more specific about how much dose we are dealing with here, I will start with the intraoral radiographs. That is probably the lowest of the doses that we kind of come across. It could range anywhere between 0.2 microsieverts to kind of 4 microsieverts. Okay, like just in case if you're wondering what microsievert means, it'll be just roughly a day of background radiation that we get every day, right? And then if you move down the list, I should say, if from dose standpoint, move up the list, right? Panoramic imaging, that would just kind of give you anything close to like 20 microsieverts. We're talking about what few days of background radiation. It's just such a low modality to speak about. Moving into cone beam CTs and medical CT, that is when, like we have to talk about variety of factors, that could impact, the dose. Just to simply put, cone beam CT kind of, find its middle ground, between the intraoral radiographs to, medical, CT. And if you're more interested in knowing the numbers, it's somewhere between like 100 to like 400 microsieverts, depending on, what manufacturer we're talking, right? That would kind of come to, close to like 10 days of background radiation. And on other end of the spectrum, like medical CT, that's substantially higher dose, by which I mean it could be anything more than like 2,000 to 3,000 millisieverts in terms of the background radiation. You can say like it is like 1 to 2 years of background radiation. So for cone beam CT, more specifically though, if you think about it, it's going to give you as much dose as it would if you're taking a transatlantic flight. Okay, so that's kind of the way I explain it to patients, when they want to relate how much dose they received.
That's a very helpful context. Chris, I think you were in a different city and may have recently taken such a transatlantic flight. So Chris may have been exposed in that flight to the same amount as a patient would receive undergoing cone beam CT.
Yeah. So the only difference is this patient would have received some benefit out of the exam. I'm not saying, Chris did not get any benefit out of that flight, not medical benefit. That's what I meant to say here. So, it's understanding, dose is kind of one thing, but again, misunderstanding it is another thing, actually. When we try to compare doses, we have to be kind of mindful of the fact that, there are some misconceptions as well, in understanding the dose. Like, for example, dentals, we always think that the dose is much lower. Probably that is the biggest risk there, I would think, because we kind of, overruling the fact that the dental procedures happen more often than the medical CT procedures. So small risks, it could easily accumulate, to execute something like a cancer induction at a later stage in a patient's life, or even in a radiation worker like us, in their life as well. And then also, another thing to notice between medical CT and cone beam CT in dental setup is that medical CT, whatever dose we are talking, it's spread over a large area. Whereas, dental CT, it is just going to be confined to a very small area. So whatever dose we are delivering, it is going to be more concentrated in that area. And that is when people talk about, thyroid cancer into the salivary glands and stuff like that. So, always put that into the context, when we talk about, dose between dental radiographs versus, medical CT.
Also, I would say from the occupational standpoint, typically in dental, participants that we monitor, it's about 20 millirem per year when they're doing traditional, X-ray, being intraoral or panoramic imaging. With the CT, what we are seeing we're seeing higher dose, and that's because of the 1 meter, at about 1 meter, there's a little more scatter, and it's about 0.4 millirem per scan that we see per year. So depending on where the person stands, it could go all the way up to 4 millirem per year or per scan. So it's really important to know where to stand and when they're interacting with the equipment.
That's very helpful, Chris. Both you and Vino have alluded to the fact that there may be some variability in how practices deliver the radiation, maybe adjusting for certain factors. I'm curious, what are some of the major drivers of variability in dose? what are some of the things that can be adjusted to optimize the delivery of radiation?
Yeah. Of all the modalities, we were talking, probably cone beam CT has probably the most, variability because of the thin beam we are talking, like it's the focus of the, radiation into the patient, small confined area. So I would just say the most, factor that affects it would be the field of view, and that is
Okay.
why different manufacturers, they have preset field of view for different types of exams. I'm talking between like a whole mouth versus, a section of a mouth, so they definitely come up with different, FOVs. And then depending on the nature of the study, the voxel size or the pixel size, most broadly called, right? And then resolutions also, like if they are focusing more on the bone or anything, they would just definitely have something really high resolution that would ask for a little higher, dose, obviously. And then the intrinsic to the protocol itself, the MA, KVP, or the exposure time that we have chosen. Thank God these days, most of the protocols, they come kind of pre-built, so the operator does not have to play around or fiddle around with that. But again, different manufacturers, they do it, differently. So that adds to the variability of, dose, in a cone beam, setting. And then probably it is kind of mostly patient oriented. Like when there is a patient motion or something, obviously the operator has to, repeat, some exams. So those kind of the things, kind of easily can add to the, a dose to the patient and also to the, operator. Again, different, ways different dental offices will approach this. Again, I cannot tell like what is kind of the most, like most active, reasoning for the dose in that particular dental practice or in that particular cone beam CT. It will be among, these reasons that I have listed them here.
Yeah, I would add
Chris?
also for the techniques that factors are MA, KVP, the exposure time. Also repeat scans. The number of times you have to redo the scan can create more radiation exposure. Basically, higher settings equals more photons equal higher dose.
Mhm.
Something that I like to think about sometimes is film dentistry or film X-ray film, and then there was a move to digital. When that happened, it was noticed that when the people would convert from film to dental, they would still run their systems like a film system, so they weren't
Uh-huh.
getting the benefit of the digital technology in reducing the dose. But a lot of times they would assume that they were having that benefit. And there's a gentleman by the name of Dr. Joel Gray who had set up QA programs to test these systems and had found that a lot of them were still running as a film system with the MA and the KVP.
That's very interesting. I've noticed myself in various dental offices that sometimes in that transition from film to digital, there comes a certain greater lackadaisical approach maybe to
Mhm.
radiation as they may think falsely that they're delivering less without the adjustment, as you mentioned, of the settings to accommodate that transition.
Yes.
I'm curious. I love to ask the experts. And sometimes as a practical matter, as we may all be patients of dental practices, what do you personally do, Vino and Chris, with respect to your own personal shielding, if at all, when you're in that chair as a patient? Do you ask for a lead shield? And for which modalities do you request it, if at all?
Okay, let me start. So obviously for medical imaging, yeah, I will definitely, ask for, shield versus if it is an intraoral radiograph, probably, like I would just shy away from that. But, for cone beam CT, I think, we should still recommend,
You would.
getting,
Okay.
yeah, I would. Yeah.
The times that I've had it's mandatory in the state that I live in to put
Yep.
a lead apron on the patient. However, when I've had the cone beam CT or intraoral panoramic, sorry, there was no lead shield required because it's just really centered around the jaw.
I see. So when you have that option, though, as a patient, when there is a shield available, should you request it regardless of the modality? As a practical advice to patients.
That's pretty much what we recommend all the the imaging centers and hospitals. As Chris rightly put, we're kind of in a environment where people are kind of taking either sides. Right now,
Yeah,
as a physicist, yes, I mean I know that the dose is not going to be as high, but I also kind of come from a background saying any little radiation it is going to be harmful. Why take chances?
yeah,
So different states, they have different regulations, and obviously the hospitals and the imaging centers will be forced to follow those regulations. And there are some states, they're kind of a little dicey. They just kind of leave it to the facilities. In such cases, I would just say, just leave it to the patient. If the patient requests for shield, just give them that. That's what I mean. There is no point in kind of arguing or kind of trying to explain it to them at that time of the the patient care. I don't think it's worth it. And especially when it comes to scanning pregnant patients,
sure.
always, they should be, shielded.
So your philosophy may be that of trying to do it as low as reasonably achievable.
That's correct.
Now, a final follow-up question. In placing that shield, do you also try to have it high up to protect the thyroid gland?
Yes, I mean that is the biggest concern. If I read anything in the literature, however low the radiation is, the biggest impacted area would be like anything in the the pituitary, right? I mean in the salivary gland,
Okay.
thyroid, and maybe in the breast area. So yes, I mean I would just do so, but caution should be taken so that the shield doesn't come in the way of imaging. That's the biggest problem of applying shielding, and that is where people started talking against shielding, because that is creating more problems than more help it is doing.
Because as Chris alluded to before, one of the biggest problems is repeat scans, where that may be the greatest source of additional redundant, unnecessary radiation exposure, in addition to Vino, to what you said in terms of field of view being too large, being one of the enormous contributors.
That's correct. That's absolutely right.
Now, Chris, you previously mentioned about in that transition from film to digital, you seem to imply that there is some ability of physicists to adjust or to optimize dose. And I think that's the good news, that there's practical things that physicists can do in practices to really optimize the delivery of radiation, to make it on one hand sufficient for the imaging needs, but on the other hand to deliver a safe amount. Can you kind of elaborate on some of this issue about practical dose optimization?
Let me take a
From,
little. Oh,
okay.
yeah, go ahead, Chris. Yeah, please.
No, go ahead, Vito. Sorry.
Okay. I just wanted to again kind of elaborate a little bit on the word optimization, obviously, right? I mean,
Okay.
quite a few sites where I went to, they always just talk about reducing the dose. Okay. Optimization is totally different than, reducing the dose. And to be honest with you, in my experience of doing CD dose optimization, in some occasions, I would have to increase the dose to give the radiologist, good quality
Good
images,
point.
Yeah, I've done that. So from that standpoint, I would think, we should go with the basic definition of optimization, which is to minimize dose without, compromising on image quality, pretty much maintaining, image quality. So that should be the first and foremost, thing that we should have it in mind before, we can just go or taking a deep dive into, optimization. So sorry, Chris, I'll let you, go through that, and then I can just take any follow-up questions on that. Please.
Yeah, as you said earlier, I would say the smallest field of view, the resolution, like don't run the X-ray machine with too high of a kVp, little things like that. Also, just what Dr. Hiatt, you alluded to it earlier, was have a plan going in to reduce, so you reduce retakes, better positioning. All those things will help optimize the dose.
Yeah. So if you wanted to elaborate a little bit more on what Chris just mentioned, from a technologist standpoint or an operator standpoint, I would just say patient positioning is probably the utmost. Like if you don't position the patient, most likely you will have to repeat the scan no matter what. So that's the first and foremost. I mean, even in the conventional CT, that's what I train people saying, isocenter the position. That's the isocenter the patient. Sorry. So that's the primary concern there. And then of course selecting the right protocol. I mean, I know that selecting the protocol comes with the clinical indication, obviously, right? That dictates, what protocol needs to be chosen. But at the same time, that also has some small nuances saying, are we using the appropriate FOV even within that protocol, to make sure, for example, like if you're scanning a pediatric patient versus adults, are we taking that into account? Those kind of things. And then resolution, I think Chris kind of mentioned that also. For high resolution scans, obviously, it is going to have a much higher dose. For example, we should not be using, a detailed implant planning protocol or a root canal evaluation protocol or anything to resolve the TMJ, issues for routine, dentistry, scanning, something like that, And then, of course, I have seen in some facilities, may not be in dental practices as much, but from my experiences working in other, cone beam CT walls, they would just have different protocols, named by physicians, named by technologists and whatnot. It shouldn't be. I mean, to my understanding, a protocol should be based on clinical diagnosis or clinical indication, not by whoever is reading it or whoever is scanning it, right? So the best approach to that is like obviously make sure you standardize the imaging protocols, so that no matter who is scanning, it's the same dose or similar dose, to the patient. And then Chris mentioned about repeat imaging, like how to minimize them at all. It's a no-brainer, obviously. Don't do anything more than what is kind of required, right? I know that there are some technologists in the world, they wanted a perfect world, so they keep repeating to get the perfect set of images, and there is nothing called perfect in the medical world. As long as it's kind of clinically, diagnosable, I think that's a good quality, image, So those kind of things, we have to kind of repeatedly educate, the imaging team to take into consideration. Last but not the least, a lot of facilities, they don't see the importance of, doing equipment QC and PM visits, So those kind of things, those kind of little things, because as a part of the QC, you would know how the tube output is behaving and how, image quality is coming out. Without that, it's all guess game, right? We don't want, the imaging facilities to be taking that route. So I would think, these are all the factors that I think, would be very useful, in kind of building a good optimization program, in a clinical setup.
Yeah, I would also add that, the Joint Commission, probably 5 years ago or longer, came out with guidance for hospitals, medical applications for CT scanners to optimize the dose, to basically review the protocols, ensure that you're using the proper protocol. Say, for example, that you're not using an adult protocol on a child. Things like that, as Vino had mentioned, very important to look at those, what protocols you are selecting.
Yeah, I mean,
Excellent.
every accrediting body, starting with ACR, Joint Commission, RadSites, they have some component of protocol reviewing and optimization as a part of the physics testing. So they all know how important it is to do that, and that's the reason why every facility is being asked to follow that routine. Yeah,
Sure. Now, Vino, you had mentioned before the importance of quality control. And I'd like to know from either you or Chris, just a little bit elaboration about what good quality control is and what the current gaps that you see in the practices you serve with respect to poor quality control.
okay. So obviously the quality control starts at the time of installing the scanner itself. You have to do the acceptance testing even at that time to make sure it performs as per the expectations. And then comes the routine annual physics survey or the routine preventive maintenance visits and stuff like that. And not to mention the technologist QC as well, right? Those kind of the routine ones comes immediately after it is being installed. And as a part of a regulatory requirements, most of the accrediting bodies, they ask for some kind of, like acceptance testing. Some ask for a, third-party neutral acceptance test, whereas some other, accrediting body accepts, if a acceptance test is done by the manufacturer themselves. Either way, it's, kind of required. And unlike that, the routine QC, most of the regulating bodies, they, ask for it and they require, sites to do it. So it becomes, no matter what, it is important aspect of, maintaining, one, image quality, and then second, maintaining the radiation, safety standards. And then, of course, comes the shielding, right? I mean, you have to make sure, like not only the occupational workers and patient, they are safe. We wanted to make sure all the others, working in that area, like common public, they are, good to work in that area too. And shielding, obviously, helps. Shielding assessments, I mean, there are multiple ways of doing it, or actually at least two ways of doing it. One, to come up with a shielding design even before the equipment is installed, and then post installation, just to go in and make sure all the shielding that is kind of promised to be in, it is still there. A physics testing will definitely, do that. I mean, shielding integrity and radiation protection survey, we call it, that kind of, makes that. And then comes the, encompassing all of these would be the radiation safety programs. A good radiation safety program should cover all of these components, into it already, and then it also should include all the calibration requirements. It could be any corrective action. Like, for example, if the physicist finds any fault with the equipment, do you have an action plan to correct it? And if so, do you maintain a documentation for that? Those kind of things, like it should, definitely exist, in an imaging, department. So I would just have, Chris add to it if he has any more, comments to that.
Yeah, I would say most common gaps, maybe in the compliance area, would be missing or incomplete acceptance test records, as you said before, no formalized protocol documentation, even seeing, where the shielding is not reassessed after the volume increase. So let's say you have a dramatic step increase in the number of patients you're seeing in a year. Remember, you're tied to 10% of the federal limit. If you get to that point, you have to monitor. And the 10% is 5,000 millirem. So if you're expected to receive over that amount, you need to start monitoring. And a lot of times what the situation was 5 years ago, 10 years ago, it's changed because now your practice has been more successful, or you've brought new technology in where people are getting exposed now than to the levels that they weren't before. For example, 11% of modern dental professionals have measurable annual dose. I'd say 5% exceed 100 millirem, and about 1% exceed about 500 millirem.
Wow. Chris, that's very helpful. Why don't we switch then from equipment to people? And in terms of monitoring radiation exposure, I think that it's important to differentiate between patients who receive cumulative radiation, perhaps every 6 months to a year or over their lifetime, versus occupational exposure received by staff. And Chris, can you kind of comment on this dichotomy and perhaps the different approaches to monitoring those two different classes of people?
Yeah, so I guess I kind of think of it this way. You have staff monitoring basically is equal to worker safety plus compliance. So
Okay.
the first question is, are employees staying well below the limits? So review your dose reports and see if they're below the limits.
Well, let me first ask you, let's go even back further for the benefit of
Okay.
the audience. How do you generate the data on those reports? What is the
Yes, so
mechanism or the badge?
a person will wear a what's called a dosimeter. Sometimes they call it a badge or a film badge, although that's not the technology anymore, but it's kind of stuck in our conversations. Basically, it's a radiation detector that will measure how much radiation exposure a person receives while they're working around an X-ray generating device or radioactive materials.
Two questions. Now, that the staff member wearing that dosimeter or that badge should, in order to simulate their environment or to accurately record the impact on their flesh, should wear it as close to their body as possible, right? Underneath the shield.
They basically, in most cases that I've seen, they're not wearing lead aprons when they're doing their X-rays. I have not seen a person wear one. It could be the states that I live in.
So my point is, you shouldn't, contrary to what I was saying, you shouldn't protect that badge. Rather, you should make it out in the open so that it
Correct.
can accurately record the radiation in your environment that you potentially could be exposed to.
Yeah, by regulation, if you if you have a lead apron on, you've created a non-uniform field. So you should put the dosimeter in the highest location or wear multiple dosimeters. So typically you would place the whole body dosimeter in the highest location where you expect to get the radiation exposure. That could be the head, the upper arms, the torso of the body, or the upper legs.
And you're coming towards the end of the reporting period. You're concerned you may have been exposed too much. As you alluded to before, in your practice, you're increasing volume. So you should take that badge and just set it aside for the final days of that period so that you're in
Always wear
compliance.
always wear the dosimeter when you're in
Okay.
the room or in the area. It's very
So then,
important to know
so
how
then
much
take us
exposure.
from, and thank you for that education, because I've seen these errors
Yes.
committed in amongst various people. Now take us from the recording of the data through that badge to reports and how that data should be used by a practice.
Yes. So the dosimeter, once we do the exchange, you turn your dosimeter in. They all get shipped to us. You put a new one. You basically put a new one on and continue. So there's no break in the monitoring. We will process that dosimeter in about 5 days, 5 to 10 days, and you'll have dose reports, dose results back. The important thing at that point is to check the dose reports to see how many folks are showing higher doses than before, who may be getting a lot of dose, more than anyone else in the area, because their technique might be different than someone else, and they need to correct their procedure. Look to see how many people exceed 100 millirem and how many exceed 500 millirem. Very important to kind of keep an eye on your workforce to verify how they're performing. And then I would even look at how many measurable doses you're seeing as compared to last year.
So Chris, your company, which is Radiation Detection Company, provides a service to dental practices whereby you receive the data, or no, you receive the badges, generate the data related to their exposure, and then just don't stop there, because what good is just a report? Rather, you then turn that around into helpful information about trends that the practice then may be able to address, maybe change.
Correct. We have tools that can show the historical trend over time, what the site has been seeing historically. We also have the ability to provide warnings or alerts to the folks if their exposure is above a certain OR threshold that they have set. We will give them a phone call to say, hey, you're trending a little higher than what you've set your warning level at.
So Chris, this is really proactive use of the dosimetry data. And I think, Vino, this data may be used by you at West Physics, because it may be an indication of how the equipment could be adjusted, not just staff practice, but also maybe the equipment or the protocols used.
Mm-hmm. That might be a little stretching, if you wanted to analyze this, because we have other tools to, let know like what the radiation output, is.
Sure.
We can get a direct way of doing it, because here we have like multiple, factors, right? Like how the employee is wearing it, the, dosimeter. To answer your question, Dr. Hiatt, I do use dosimeters on a daily basis. So there are multiple ways, dosimeters could be used, but in dental practices, like if you're wearing a shield, obviously you have to wear it on the outside of it. The best place to put the dosimeter would be your collar level,
Yes.
outside for the whole body. However, things could be different if you're talking about a pregnant worker. Okay, for pregnant worker, if they wanted to know how much the fetus is going to get, that is going to be on the inside of the lead apron and the waist level, in the abdomen level. So those are kind of two major, differences. Now, when we look at this, graph that we are getting, it also depends on like what dosimeter we are getting this reading from, right? So that will also give us much more, insight. And in our practices, of course, we have like, physicists who are wearing the dosimeter, and we use the dosimeters where you can get instant reading. Like when you come home, you can switch a button and it is going to give you kind of instant, reading at the end of the day. So that's kind of the benefit of having all the semiconductor-based, dosimeter these days. So to kind of know the trending for the employees, and just the way Chris, put it out there, we have our own internal thresholds. And if anybody is trending towards that, and if it is going higher, more than anything, this is going to give you the radiation safety behavior and the workload, for that individual. Yes, there is an indirect way of knowing if that particular equipment is kind of giving this much of a, higher dose. I would usually go with a more direct way of measuring it than to be relying on this piece of data. I will use this data, but then I will use it as a supplemental data. You know what I mean?
Now, Chris, about using this data, how do you recommend practices use it proactively as opposed to just passively?
Yeah, and I would say that dosimetry is a tool to help bridge that gap between the monitoring, say, that Vino's team would do. So, for example, I would stop treating dosimetry as a quarterly compliance invoice or a chore. Start treating it as a quality signal. So,
Okay.
to do that, I would say track the percentage of people with measurable doses. Investigate anything that's abnormal, a spike over baseline. Let's say you normally run at about 20 milligram. Now you see somebody at 100. What's going on? Investigate that. Don't just say, oh, we're still below the limit and continue on. I would also look at your exposure trends compared to your volume of work that you're doing. That will have an impact on if the doses are higher than normal or lower than normal. Review repeat scan frequency per month. That's a big one. If you have a way to track that, that might trigger that, hey, I need to do a better job of training. A lot of ways that you can use dosimetry to help. Even in dosimetry, say in dentistry, the area monitor is a good indicator of low exposure environments and how much radiation the team might be getting if they're not all wearing dosimeters.
So this is always a topic at the hospital level or at the imaging center level. This is always a topic in the radiation safety committee meeting, where, if an employee is trending, even though, as Chris mentioned, if they are not, passing any thresholds, at least if they are trending. And that's the reason why most of the, imaging centers and hospitals, they have two ALARA levels, like one is kind of a much milder one, like ALARA level 1, which would be just kind of even 10% or even less than what the threshold will be. And then there will be another one, level 2, like when employees cross certain level, they have like different follow-up, procedure, kind of asking for the employee to bring back to the radiation safety committee all the radiation safety behaviors they have been following. And if there is any, gap in the, learning for them, that is when, we talk about like, should we need to give them a refresher training or education, radiation safety training and all. So those kind of things, we use it, and it's kind of a, important agenda item in the radiation safety committee meetings.
I really appreciate and love how both of you treat data as not something static, lifeless, in Chris's words, a compliance chore, but rather you bring that data to life. You proactively, as opposed to passively, make meaning of it. Going from information to data to knowledge to wisdom, you're actually making it important, for the health of the occupational workers and for the patients. What I would love to do is to kind of bring everything together and to talk about all aspects of what we've been discussing, and for you really to pull out what you perceive in your interaction with numerous dental practice. What are the common gaps in dental practices with respect to, the use of data, monitoring, optimization? What would you say are the biggest gaps, and what can dental practices do to avoid those common pitfalls?
So yeah, I mean, there is no one size fits all. Okay. Yeah, I mean, one site or maybe more sites will be just having the same findings as the others, but does not mean that that's the only, main, gap, that we identify in dental practices. It could be anything between like inconsistent, protocol standardization, as we talked. And, important aspect, we didn't kind of talk more in the earlier stages was lack of periodic, shielding reassessment. What I mean by that is they might start increasing the patient volume, but then the previous shielding design they did that did not take into account that extra patient workload. Or if they might have done a recent upgrade to their equipment, that needs to be taken into account for shielding reassessments. And most of the times when inspector goes in to a site or an imaging facility, most of the times they would find incomplete documentation. It could be something what Chris mentioned, like it could be dosimetry records, or it could be anything to do with the QC. It varies.
Yep.
It could be there. And we just briefly talked about how to wear the badges or the dosimeters. It could be in one of my recent experiences, like one of these physician operators, when he was performing not in a dental practice but in a IR setup, where he was not wearing a ring badge when his hands were in the primary beam, and the NRC was obviously not happy about it, and then they had to cite the facility for that. So obviously, if you're not using the badge, or if you're not using the badge appropriately, that could lead to more issues. And all the things that we talked about in the previous 5 minutes ago, that will all hold true. All the things that we are gaining there, we would be missing if you don't have that piece of information. And of course, I'm big on education. Okay, no matter how much how many years you're doing this, you have to update yourself, refresh yourself with all the updated information. If you ask me like any one thing that kind of sticks in my mind, I would just go back into the facilities priorities, basically. Like, why do you want it to do radiation safety? Do you want it to do it just to make the compliance, or you really wanted to focus on the quality? So depending on that, and even without mentioning that, either ways, safety should be at the core of your radiation safety program, right? So obviously I want every facility to take a team approach, because radiation safety is everybody's responsibility. You cannot just blame somebody for not doing the job. And for that reason, the leadership should be kind of more open to communication rather than being punitive. So that's what, yeah. Go ahead,
That's
Dr.
wonderful. Chris, what do you think about what Vino says in terms of having safety and quality permeate the culture? Does it need to come from the top, from leadership?
I believe it always comes from the top. Consistent badge wear, walking around, seeing someone not wearing a dosimeter is very important, because people forget, or they're just like, oh, I left it in my car. I don't want to go out to my car and get it, right? So there's just a lot of ways that leadership can help in this aspect.
I'd like to include one note about accreditation. You two are expert in advising practices, and you see the gaps and how they could be addressed. One thing about accreditation is that it provides not to supplant what you do, but I think reinforces what you do in terms of promoting quality and safety. And so accreditation, whether it be through RadSite or some other body, gives that independent review and external verification, not only with respect to equipment performance, but also on the people side, the quality control processes, the radiation safety policies, documentation standards to assure that protocols are right and optimization is pursued. And I think that accreditation gives that structured framework such that you can have not just a chore for purposes of compliance, but a means whereby you can really continuously improve for the benefit both of patients and staff. And it also shows, your staff and your patients that you're committed to this culture of promotion of safety and quality. Any thoughts now as we come to the conclusion before our Q&A from Vino or Chris with respect to any of the key takeaways that you really want to reiterate and have people take home?
So if you ask me as a physicist, optimization and radiation safety overall is often simple and it's very impactful. and just baby steps towards that is going to land us in a big win, like for both operators and for the the patients alike. And of course, we're going to work together as a team, radiologist, technologist, and physicist, and any ancillary staff. So I just wanted to reiterate that it's a team game, so everybody is in it.
Wonderful. Chris?
No, I would say that accreditation programs are very important. I've seen the evolution of the Department of Energy's laboratory accreditation, DOLAP, and also NAVLAP programs for dosimetry services, where there was one time where you could just put your shingle up and become a dosimetry service, and there was no requirement, no technical requirement or regulatory requirement. So I think it's important to have standards. And also to have guidance on, what's the best way to do things, and ensure that folks are, when you go from one dental office to another, that things are being done correctly, and that they're doing things right. I would also say something that we haven't really discussed here and things, but we all get dental X-rays, right? And I've seen some crazy stuff where they've rigged their exposure buttons so they're not really behind the shield. They're defeated the shield, and they're in the room with you, or they have a gun and they're shooting it across at themselves. Just crazy things like that. Just keep in mind time distance shielding, and keep your head about what you're doing in the field.
That's wonderful. Well, Chris and Vino, I'd just really like to thank you for sharing your time, your insights. I think that's been very beneficial to our audience. And what I'd like to do is for the audience is to really open it up to your questions in these final minutes. If you have any questions to ask us.
Dr. Hiatt, I'm seeing some questions in the Q&A section. So you can go through that if you want now.
Great. Why don't we take that first one, Vino? Would you like to first read it and just give your response?
Okay. Can you say a few words if there is a methodology for patient dose measurement for cone beam CT in more or less analogous way as a standard CT using the ACR spreadsheet by calculating effective dose from CTDI and DLP? Great question. As physicists, we have been struggling so hard, in kind of standardizing it for cone beam CT. There were a lot of back and forth between the accrediting bodies and, like regulatory agencies in the way we do it, because like when cone beam CT was at its inception, right? We were pretty much trying to treat cone beam CT as the conventional CT as well. And we all knew that, that was not the appropriate way to, do the measurements. Now, things are going to be trickier here because, in cone beam CT, the pencil beam, that we have, pretty much it's a cone beam, right? So that makes it really difficult for us to measure anything because, like the way the configuration of the beam, it is not going to give us any accurate results. So the best way to do that is, the physics companies and the regulatory agencies, they agreed upon this common methodology where instead of bringing any phantoms or anything and measure the, the scatter radiation, you'll be placing a meter on the detector and we'll be measuring the direct exposure. And from that, you can do some calculations and get, all the effective dose and the DLP and whatnot. So to answer your question straight away, yes, there is a method to do it. The only thing is that it's not as straightforward as you would do in a conventional, CT. So hope that answered the question.
Great.
So should I move on to the next? Yeah, okay. I think that one is also related to, physics, so I'll take that.
Yeah.
Let me read the question. Should cone beam CT units to be housed in a dedicated room with shielded rooms, equipped with shielded doors, leaded glass or interlocks, etc., like fixed radiographic units, for example? There is no single answer to this question because, not that I don't know the answer to that, but, from a physics standpoint, the shielding is pretty much determined by the workload, by the distance, depending on how big the room is, depending on where the operator is going to be, depending on like who is going to be on the other side of the room. So there are a lot of, factors. But if you're asking me kind of a straight answer, I would think I would kind of err on the safer side, than to be sorry, right? So I always just think that the cone beam CT, if the room is too small, obviously, should be kept in a shielded room, just the way you would have it for a radiographic unit, or any other, radiation producing equipment. But then if you can convince yourself saying that the room is such, a big room where people are not going to be around that, room as much, probably you can make a case there, but either ways I think you have to do a calculation to find out which way it is heading.
Great. I have one from the audience, which is related to smaller dental practices, general practices without an in-house physicist. What's a reasonable and defensible approach to ongoing radiation monitoring and quality assurance? What do you do if you're a small practice and you don't have your own physicist?
Okay. I would just say, like, build your own team. Just name your radiation safety officer. He's responsible for anything radiation safety related. And, depending on like what different accrediting bodies ask for in credentialing requirement, that person should meet. And quite often times, the radiation safety officer will have to take a lot of refresher, trainings and all. So, I'm not going to get into that. And whoever that person is, will be solely responsible, for whatever is happening in that, practice. And I would suggest, to that person to conduct, periodic internal audits, okay, just to make sure all the documentation is all maintained and anything in the monitoring activities, and then always open to, peer, feedback, within the department. So those kind of things will help in small practices, in nailing it.
Speaking of documentation, here's another question from the audience. Chris, this maybe you have an insight into this. With respect to documentation, if a practice were ever audited or faced some type of regulatory inquiry, what documentation around cone beam CT use and radiation safety would you want to have readily available?
I would say the complete dose reports and possibly the Form 5s that you provided the employees if they needed those, if it was required by the state to provide, would be a good starting point, because that will show what the occupational exposure is. Then there's always the annual surveys that have to be done on the system to show what its output is, and if that's changed or if the shielding has changed.
Great. Very good. And Vino, did you have a final comment?
No, I think there are two more questions in the QA, so I just wanted to bring it up here too, if we have time.
What we can do is, for those who submitted them, we can answer any of those that came in separately by email. Vino, unless you see one that's really compelling.
No, that's kind of one easy answer I have. I can answer this. Does the cone beam CT give less radiation compared to digital X-rays? Again, different variabilities and all, but if you wanted to do a ballpark, I would think it's kind of both are comparable. If you're talking about chest X-rays versus, cone beam CT, I would think, they kind of give pretty much, similar doses.
Got it. And then that final question, just for sake of completeness.
Okay, so probably I do not know whether I will be able to answer that, but I will read the question. Monthly dose tracking. In April, does clinic usually have more patients or procedure?
So maybe I can take that. The trending that I've seen in dental data is typically the end of the year. We'll see, because people are starting to come up to their insurance limits. So we'll see a uptick in procedures then. And I would even say we saw a big post-COVID surge, which was kind of abnormal, where a lot of people were going back and getting dental work done right away.
Excellent, Chris. Vino and Chris, thank you. Excellent insights. I'd like to turn it now back over to Andy for final notes.
RadSite would like to thank our moderator, Dr. Mark Hiatt, and our panelists, Dr. Vino Duraraj and Chris Passmore. Just a reminder that today's webinar has been recorded. Please visit our webinar page on RadSite's website at www.radsitequality.com or our YouTube channel for this webinar recording and past webinar recordings. If you would like more information about RadSite's accreditation programs, contact us at info@radsitequality.com. And thank you again for joining us today. We look forward to seeing you again at future webinars.